Hello, and let's get started for today's oncology department meeting. We're going to go over our technology update. My name is Carly Viola, and I'm a registered nurse here at the Massey Cancer Center. I work in the infusion area, so I work with all the patients getting chemotherapy treatments and biotherapy treatments and blood transfusions. In order to implement a new electronic system that will help serve our ambulatory oncology departments in a very comprehensive manner, there are several stakeholders who must be included in the strategic planning. A lot of those stakeholders are here in this room, and a lot of them we need to get in this room for our future meetings. Any new change that we start as a group, we need to always have buy-in from our ambulatory leadership, such as our nursing officers, directors, and chief medical officer. Those people that are in those designated leadership positions really help to influence the culture here at the Massey Cancer Center and help for our colleagues and our peers to accept changes and implement new processes. Beyond that, representatives from all members of clinical care, such as nursing, physicians, mid-level providers, pharmacists, and physical therapists, all these people that are end users that have a lot of contact with our information systems, must have equal contributions to how the interface and usability of the system will be selected and implemented. Additionally, those members of the administrative staff, such as those in the front office that check in patients, those who help with our scheduling needs, and those who help with billing and prior authorization, really need to make sure that their voice is heard, because that is how we efficiently assist patients gain access to expensive cancer therapies and how we allow for them to have the most accurate amount of billing for their treatments that they do receive here. So that's a review of our stakeholders. Moving on, I think we should start with letting you know what the agenda is for this meeting. You all have a meeting agenda in front of you. I think first we need to start with introductions. And then we're going to define our current state. We're going to look at outcomes, patient privacy, and then we're going to develop a strategic timeline. Unfortunately, in the ambulatory oncology setting, we get very comfortable in our own workflows and we exist in very separate silos. So we have many subject matter experts in your respective fields and services, but we don't really know what every single person in this room does on a day-to-day basis and how they contribute to the bigger picture of our patients' care. Once we establish who we are as a group, then we need to figure out what is our perfect world, what is the perfect day for us. Our new information system should be capable of getting us to a place of efficiency that we believe to be perfect and the best for our patients. After that, we will describe how to measure the outcomes associated with the new information system, as well as understand the key components needed to maintain the privacy of our patients. Finally, we're going to lay out that strategic plan with a timeline, which we are hopeful to have this whole project up and running within the next 6 months. We'll talk more about that in a little bit. Let's start off with introductions. I'll start with myself. I'm Carly. I am a nurse. But also, I'm an electronic health record user. I use it in many different ways in every single hour of every single day I'm at work. I rely on the electronic record to be accurate as I read the updates on my patient's progress notes. I use it to document the infusions that I give to patients. I use it to activate chemotherapy orders, to verify informed consents, to verify important diagnostic data such as the injection fraction of my patients before I give them cardiotoxic chemotherapies. And I document every intervention that I do, every IV that I start, every port that I access, every patient that I counsel. That all goes into their electronic health record. Beyond my daily work, there's even more electronic system functions that influence my workflow. How my patients get onto my schedule, how my interventions are billed, and then thereby the Massey Cancer gets compensated and thereby I get paid for the work I do, and even how much time my patients have to wait for their treatments and appointments. All those kind of peripheral ideas of the electronic health record and the health system really do affect my day-to-day workflow. I think this would be a great time for everyone to introduce themselves and explain what your role is and how the electronic health system affects your role. Now that we've all introduced one another, I want to describe how our current state is. I have this visual of people working in these individual boxes, and I think that's unfortunately how we really work right now at Massey, and I think we have a lot of opportunity for improvement there. We have a separate electronic health system program for radiology, a separate program for patient documentation, a separate program for billing, and a fourth separate program for scheduling. That is so many different programs. Our front office staff is using different programs than our doctors, who use different programs from our radiologists, who use different programs from the billing department. And even though these four systems can integrate and quote unquote speak to one another, we all know, and we see it every single day, how these different systems impact our patients, how things fall through the cracks, treatments get delayed, diagnoses get changed based on new and updated information. And ultimately, it's our patients and their families that suffer from our broken, fragmented system. What's more is our very dire need for all orders to be electronic. We are still using paper orders for certain chemotherapies, certain ancillary drugs, such as insulin, even blood transfusions. We need CPOE, computerized provider order entry, to help drive our orders and help keep all of our cancer center interventions in line with current evidence-based practice. So we're going to take a few minutes to talk about our desired state. I want everyone in this room to close your eyes and imagine a perfect day at work. All your patients are on time. All your labs are resulted in a timely manner. There are no major systematic delays, no computer glitches, and you even got out of work on time. Now open your eyes. You think that this sounds like a fantasy, but we can strive together to make the perfect electronic health system that actually helps us instead of hinders us. An essential upgrade that we need is for one electronic system that is truly interoperable across all needs: clinical, scheduling, billing, and imaging. High-level interoperability reduces time for providers to prepare for their clinics, as well as provides less time for our administrative staff used in the check-in, check-out process and scheduling processes. The results of this time saved because of the higher level of interoperability helps us have more time to spend with our patients, which adds value to the patient experience. So we have this key to interoperability here. We need to address a low-cost interface combined with a uniform messaging standards, combined with privacy, which we'll talk more about later, as well as education for our providers and all of our end users. This is the key to keeping all of our desired state, perfect world vision intact. Within the highly interoperable system, we want to lead to less time wasted and more time efficiently caring for our patients. But how we measure that efficacy will depend on our interventions. It's important that we make sure all of our outcomes always revolve around our patients and how our patients benefit from our actions. Safety and quality are essential, and they are always number one. The quality domains that are specific to the usability and efficacy of an information system include data completeness, data consistency, data credibility, and data timeliness. Those four subjects all result in the outcomes such as decreased patient wait times, decreased delays in care, increase in meaningful use, which correlates to more accurate and comprehensive billing. Both our clinical information being input into the system will be both complete and consistent, leading to highly effective continuity of care as our patients in the ambulatory care center transfer within our specialty services. So what this means is our patients are in radiation oncology versus in the chemotherapy transfusion area versus in the clinic versus seeing their surgical oncology provider. It doesn't matter where the patient is in the process. The whole system is one. It's interfaced with each other. It overlaps, and there's no guessing what the information is. The information is transparent. With the news being constant on threats of hacking, we see it every day. It's natural to have some reservations about upgrading our electronic health records and programs into one system. However, there are many safety steps that we can take to maintain the privacy of our patients and ensuring that their information does not get into the wrong hands. Our leadership specifically needs to be dedicated to allowing our information technology department here at the Virginia Commonwealth University to determine what resources and funding is appropriate to maintain the antivirus, anti-spyware, and patient data oversight that is needed for a high level of trust. The Information Technology Department must have independent oversight to monitor who accesses patients' records and have a systematic chain of command for reporting staff infractions. It should not come just from the manager of that department. It should come from an independent source saying, we've noticed there's been an infraction and here's what we need you to do to resolve it. Constant vigilance, risk reassessment, testing of spyware, and even simulating hacks to help prepare our end users are all responsibilities of the Information Technology Department that we as clinical providers must support their efforts to keep our information system as safe as possible. So instead of referring to the Information Technology Department as, this other group of computer nerds that we don't have to interact with very often, we need to understand that they are a vital component to the success of our ambulatory cancer center. All right, now we're going to look at this timeline. It may come off very optimistic and aggressive, but please keep in mind that we already have the systems we want. We are not rebuilding the wheel here. We are simply restructuring the wheel, and we're making it function more efficiently. Here is our 5-step plan. Steps 3 and 4 are kind of simultaneous, which is why they have their own, share an arrow. The first step is here. Each representative from their area needs to detail out what their workflow needs are. Go back to that imaginary perfect day. Write it down. Bring it back to our meeting next week. Step 1. We have 1 week to finish. We need to get our representatives engaged, nursing, pharmacy, PT, ancillary staff, surgery, radiology, billing, prior auth. Everyone needs a representative, and they all need to bring the reports to our meeting next week. Step 2 is here, design team with informatics department. We will collaborate, which will be mostly from our leadership team, collaborate with informatics, build the bridges and the upgrades to our current existing program, and transfer the way we use the scheduling, the billing, and how we receive diagnostic imaging into our new upgraded and inclusive system. This step will be very time intensive and will take about 2 to 3 months. We know the functionality exists, we just have to individualize it to our cancer center needs. After that system is built and redesigned, we will do testing and training over the next month. That's this third arrow here. The reason testing and training can be done simultaneously is because we can train on the test environment and make suggestions based on the feedback that our end users give during testing. This is kind of what you would consider a plan, do, study, act rapid cycle here in this third step. This testing and education phase will last approximately 1 to 2 months, which takes us to about 5 months or so, giving us about a month pad to make any fine-tune any issues, and we will go live within 6 months. With one comment over here about training, the education will be threefold. It will include online tutorials, in-person training, and even one-on-one skill mastery, meaning you will be paired with an informatics specialist who knows the skill set that you need, and you will be able to show them what you know, and they will be able to fill in any gaps that might exist still after those first 2 steps. Education will be the largest support and focus of our resources because it is important that we empower and prepare our staff and peers to become successful in utilizing the new system. Within 6 months of today, we will be functioning in one cohesive information system. How exciting is that? I know that 6 months seems like an aggressive timeline, but I assure you that with the proper resources, structured strategic plan, and education, we can get our electronic system to a higher functioning and safer place for our patient care. We're going to rely on our leadership, we're going to rely on our teamwork, and we're going to get success because we're going to do it together. Thank you very much for attending this department meeting, and we will see you next week with your descriptions of your perfect desired states.